Hello, my name is Brian Wesley Johnson, and I'm the CEO and publisher of Soulivity.com. Looking ahead to editorial discussions that are of great importance to all of you, our readers and listeners, we have created an ongoing special editorial feature section dedicated to assessing health access and the lack of equity facing the majority of Americans. This special editorial commitment is part of a growing discussion which focuses on challenges and solutions facing communities across the United States. Soulivity will spotlight widely known health inequities, the critical importance of broadening health research, valuable guidance and insights from renowned health professionals, and the accredited resources necessary to empower and mobilize our highly connected and socially active audiences. And we're looking forward to providing you even more empowered content in the near future. Hello to all of you from around the world. I want to thank you for joining us for our inaugural Bridging the Gap Health Forum. My name is Brian Wesley Johnson, and I'm the founder and CEO of Soulivity, and it is my pleasure to be your host and moderator for today. Now, each month, our health forums are dedicated to raising awareness about important health topics, including the latest trends, research, and resources for creating health equity for all. Now, before we begin, I need to go over a little bit of housekeeping. During this summit, we ask you be respectful to your fellow attendees and a panelist. And while we honor and respect discourse, we require both panelists and attendees to maintain a high level of civility. Now, attendees, if you have comments or questions during today's forum, feel free to post them throughout the event. And as we'll post some of those to our larger audience during our time together today. Now, there'll be certain questions posed to our panelists during the question and answer period that's going to happen later on in the program. And so with that, let's meet our esteemed group of panelists for today's forum on stigma, a national crisis. Now, these are well-accomplished professionals, so let's honor each of their introductions. Kevin Fischer is the executive director of NAMI Michigan. Now, NAMI, the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. A retired businessman, Kevin joined NAMI as a volunteer in 2011 after his oldest son, Dominique, was diagnosed with a mental illness in late 2007 and was lost to suicide in 2010. Now, after serving on the NAMI Michigan Board of Directors as the NAMI Walks chairperson for 2 years, and then as board vice president for 2 years, Kevin accepted the role of executive director in 2014. Now, a mental health and suicide prevention advocate, Kevin is the founder and director of the Dominique Fischer Memorial Foundation, serves on the board of directors of several behavioral health organizations throughout Michigan, including Governor Whitmer's Suicide Prevention Commission, the Michigan Department of Health and Human Services Mental Health Diversion Council, and Behavioral Health Advisory Council, Disability Rights Protection and Advocacy for Individuals with Mental Illness Advisory Board, and is a member of the Crisis Intervention Team International Board of Directors. Quoted as saying, "This is his last job, his last fight. Kevin is dedicated to eliminating the stigma of mental illness, which he considers the leading barrier to the early diagnosis and treatment, which leads to better outcomes for all." Welcome, Mr. Fischer.
Thank you, Brian. Thanks for having me.
Absolutely. Dr. Donna Grant Mills is a professional and an associate dean for student affairs and admissions at the Howard University College of Dentistry. She also serves as principal investigator for the Robert Wood Johnson Foundation Summer Health Professions Education Program, co-investigator for the Health Resource and Services Administration Scholarships for Disadvantaged Students Program, and the College of Dentistry representative for the Health Sciences Interprofessional Education Work Group at Howard University. Now, Dr. Grant Mills is responsible for leading administration and the directing of implementation and operations of the Robert Wood Johnson Foundation projects, recruitment component of the HRS Disadvantaged Students Program, and health sciences IPE activities. She has published and presented scholarly work in the U.S. and abroad. Her international presentations have been in Salvador, Brazil, and Barcelona, Spain. She is co-author of the book Howard University College of Dentistry at 140 Years, Mission, Legacy, and Promise. She's also the contributor to the National Institutes of Health 2021 report, Oral Health in America, Advances and Challenges. She is a fellow of the International College of Dentists and the American College of Dentists. She also holds membership in the American Dental Education Association, the National Dental Association, and the Robert T. Freeman Dental Society. And welcome to you, Dr. Grant Mills. Dr. Chanza Baytop is the Vice President in Public Health Practice at Westat, a research consulting firm in Rockville, Maryland. Now, Dr. Baytop has more than 20 years of applied public health research and experience focused on health equity and reducing racial and ethnic health disparities in chronic disease, maternal and child health, and HIV/AIDS. Dr. Baytop's extensive experience as a consultant to federal clients includes using mixed methods for evaluation and translating research findings into evidence-based practice in community and health system settings. Currently at Westat, Dr. Baytop directs the Community Engagement Technical Assistance Center in support of the National Institutes of Health Community Engagement Alliance, also known as SEAL, that aims to promote health equity, improve health outcomes, and strengthen partnerships through community-engaged research. Dr. Baytop is also currently the co-director of the Westat Elevating Equity Council, a cross-company initiative to assist staff in centering equity in the work of all sectors. Dr. Baytop has a doctorate of public health from Johns Hopkins Bloomberg School of Public Health and a master's of public health from Boston University School of Public Health. Welcome to you, Dr. Baytop. We also have another panelist that's going to be joining us in just a second. We are just waiting for her to come in, but we're going to go ahead and get started with our first round of questions for our panelists today, talking about stigma. I'm going to go to you first, Kevin, on this, because you've done a lot of work specifically on battling this as it regards to mental illness. So let's level set our discussion today in saying this. According to the National Institutes of Health, stigma is a well-documented barrier to the health-seeking behavior, engagement in care, and adherence to treatment across a range of health conditions globally. Based on your experience, Mr. Fischer, how do you define it?
Stigma, in layman's terms, to me, is the mark of disgrace, impinged upon a person or circumstance. In terms of how it impacts people with mental illness, it's making you feel less than. It's making you feel like mental illness was a choice. It's making you feel like your character is weak or your faith may be weak. And it's making a person feel that that circumstance is their fault. Stigma is the leading barrier to the early diagnosis and treatment that leads to better outcomes. And frankly, in the space of mental health, and when I say mental health, it's all behavioral health care, whether it's substance use disorder, suicide prevention. Stigma kills. and I'm very blunt about that. My son, when he was diagnosed, was very engaged in his treatment. And it was only after friends and family learned of his diagnosis that they made him feel ashamed of it. They made him feel that it was his fault. He heard the stereotypical, you just need to focus harder. You need to pull yourself up by your bootstraps. Mental illness is a medical diagnosis. He didn't choose that. And when you have voices, my son was diagnosed with schizophrenia and bipolar disorder. When you have voices in your head telling you that God works for you, you are way past bootstraps. And we have to encourage, not discourage people to get help. And that's what stigma does. Stigma isolates you, makes you feel that it's your fault. And it caused, in his situation and many others, it causes people to drop out of care. It causes you to stop taking your medication, to stop going to treatment. You end up self-medicating and you end up going down a dark road, which led us to, losing my son to suicide.
Wow, thank you for that. And I see you nodding, Dr. Baytop, on this. What's your take on stigma as it relates to the work that you're doing?
So similar to Kevin, I do think I agree with his definition. I also agree that the stereotyping, the labeling, the disgracing can make people feel like not just mental illness, but even a chronic condition is their fault, right? To the extent that you go to the doctor, like you said, Kevin, they're more likely to drop out of care or not seek care because there's this idea that it's your behavior, it's your fault, it's your choice, not taking into account there are so many other things in a person's lived experience, their environment, that contribute to the choices that they make or the choices that they don't have in order to adhere to treatment, especially when it comes to diet and exercise. I mean, there are many of our Black and Brown communities that are in areas that are very low resource with food deserts and not safe places to exercise or even being able to afford to go to a gym. So to come in and say, just like you said, Kevin, pull yourself up, just go ahead and exercise and diet and you'll be fine. That again, it puts the onus on the individual and not recognizing that there's more to a person than their health condition and than their diagnosis, that a person is more than that. So, and I think our health system sometimes does a disservice in stereotyping and labeling people when they come through the door. You also have intersectionalities of different stigmas, plus discrimination, and you come to the door that you might be treated a certain way, that why would you want to go back? Why have hope that things could change? So that's why I'm shaking my head. And I'm also, Kevin, sorry for your loss.
Thank you.
Thank you for that, Dr. Perry. Dr. Baytop, I should say. I want to welcome Dr. Valencia Perry to the panel, who's a bilingual and dialectal speech language pathologist and assistant professor of child language and sociolinguistics in the Department of Communication Sciences and Disorders at Howard University. I want to welcome you to this discussion as well. Thank you for being here. Want to go to Dr. Grant Mills on this. I know that you've been doing a lot of work at Howard University when it comes to stigma and how it relates to the interprofessional committee that you had co-founded. Can you tell us a little bit about your experience in regards to stigma?
Yes, sure. Based on my experience as an oral health care provider and interprofessional educator, I define stigma particularly as it relates to oral health as a distinctive health stigma that has its roots deeply bedded in external forces such as stereotyping, discrimination, and the unequal distribution of health services. And recent literature says to us, it shows us that when these forces are applied, it imposes an internal process on individuals, groups, and populations. And it takes the form of shame, embarrassment, and low self-esteem that negatively impacts one's sense of belonging. And then the oral health stigma is further magnified by a societal structure that perpetuates the stigma across the lifespan and then passes it on from generation to generation. My personal experience with stigma comes from growing up in an area where there was limited access to care, very few providers. I grew up in a time where there were only a few dentists. Few people had monies to take their children or take the family to the dentist. And there were very few providers who were not of color that would provide care. So that's what I remember. Those were my early beginnings in accessing the healthcare system that was woefully inadequate. And what was embedded in me as a child was to be part of a team that would address the lack of care, increase that access, and also increase access to careers. And as a provider and an educator, I am fortunate to be part of this interprofessional collaborative team at Howard University so that across the disciplines, we work together to prepare the next generation for their role in battling stigma and reducing health disparities.
Thank you so much for that. And I'll go to you, Dr. Perry, for your insights based upon your professional experience when regards to stigma.
Sure. Thank you for having me. So from the perspective of a speech language pathologist, we practice in healthcare settings, education settings, private practice, and I'm, of course, also a member of the Howard University Interprofessional Education Committee, or IPE committee. And it's a wonderful opportunity for me to get to learn about how stigma translates in different regards, but specifically from a speech and language perspective. We see stigma with regard, and that's another reason I'm so glad you introduced me as a bilingual speech language pathologist and bidialectal, because there's stigma right there, acknowledging that I speak African American English and that it is a language. It is a separate linguistic system. We have different tenses than mainstream American English. We have different words. We have different speech sounds. And so the way we say certain words regionally, as well as just across the culture, may differ from mainstream English variety. So a stigma comes in language use. There was a case in 1977 in Ann Arbor, Michigan, the Ann Arbor case, where a variety of African-American children were misdiagnosed as having intellectual disability because they spoke African-American English. So stigma is when healthcare professionals use language as a barrier and as a means of power to keep certain people from having access to their rights. Stigma is when we deny people their rights and privileges because of something that we may have an underlying assumption or an underlying belief about someone based on an attribute that differs from what our mindset is aligned. So, we're just here to speak about these issues because power is oftentimes embedded in communication and in language. And so we want to provide people with opportunities to have access to healthcare, to have access to services, to have access to their rights as citizens in this country. So I'm happy to be here and to shed light on what my perspective of stigma is from a speech language pathologist, because a lot of our children in special education are misdiagnosed. African-American children are it's about 1.8, almost 2 times more likely to be diagnosed with the special education eligible category just by virtue, and I believe because of their language, because most children in special education receive speech and language services. And so there are some barriers here that the system has put up in place that prevent people from getting the help that they need when they need it. And as you mentioned, Mr. Fischer, I want to say Dr. Fischer, because your experiences definitely qualify you for that doctorate. You get an honorary doctorate by virtue of taking pain and turning it into purpose. And, so many people don't get opportunities to get the help because the system does not allow them to progress through it to get the help. The channels are blocked for them. And so that is stigma for me, is when you are not allowed to get what is rightfully due to you because of a misalignment in the system.
All right. I think we're off to the races now. Thank you for that, Dr. Perry. Listen, we're going to take a quick break. But when we come back, we're going to dive a little bit deeper into this. because I want to know a little bit deeper about this impact, right? I mean, we're kind of defined what stigma is, but I really want to know deep in terms of each of you, what does stigma look like in real life terms with patients, with students, with the world that you serve? So we're going to take this quick break and we'll be right back with more of our health forum in just a second. Hi there, this is Brian with Soulivity.com. I want to share some exciting news about our new Aspire Academy by Soulivity. Now, you probably want to know what the Aspire Academy by Soulivity is. Well, it exclusively connects you with people around the globe and who share the intense desire to improve themselves and create a better life for themselves today. There's classes, there's workshops, there's live events, and even more exclusively just for you. You see, I wanted you to have a safe space where you could grow, you can learn, and it would empower you in all aspects of your life, including your mind, your body, and your soul. So how do you get started? Well, it is so easy. First of all, the best part, joining Aspire Academy is absolutely free. Just click on the Join Now button, sign up, and begin your journey. As a special part of this invitation to you, there are some free courses that are available for you to try from our amazing roster of coaches and collaborators. It's our way of saying thank you for all of your support and being with us along our journey of expansion. I hope you enjoy the Aspire Academy by Soulivity today. Start the process. Learn more about your passion, your purpose, and how to live a higher quality life. And we're back with more of our Bridging the Gap Health Forum on Stigma, a National Crisis. Another question, and I'm going to go to you, Dr. Baytop, to begin this next round of question and answer. Based upon the definitions that you gave earlier, how does stigma impact your work and the communities that you serve?
So just to give a little more context to answer that question about the work that I do. So as I mentioned, Westat is a research consulting firm. And so we primarily contract with the government to help develop and evaluate programs to reduce racial and ethnic health disparities. At least my work is in that area. The company itself does work in transportation, education, social economic policy, et cetera, et cetera. What I think is the most the impact that stigma has in conducting research or programming really is what gets at the heart of equity in research, because I think that oftentimes researchers are going off of the stereotypes and the implicit biases about populations, about individuals, about particular groups. And sometimes they're not asking the right questions, or they're designing interventions that are not necessarily getting at the root of the issues. As I mentioned before about stigma, there are a lot of programs that are really based on targeting the individual and the individual's behavior rather than addressing the individual's social determinants of health, their environment, their lived experiences, their the healthcare system, the social and physical space that they live in. The work that we are doing right now, we support academic institutions to work in partnership with communities. So the communities are supposed to be at the table to help with designing those questions, research questions, so they're relevant for the individuals who are most likely affected by the intervention, rather than a researcher coming in with their own preconceived notions of someone, what they may or may not be based on their attributes, and designing it based on their own experiences, which often don't necessarily match up with the individuals that they're serving, right? So I think that I commend NIH for trying to do this kind of work where you have the community in partnership with researchers to help drive the development and the evaluation of effective interventions, but also not just effective, but sustainable. Because I think often many of our Black and Brown communities tend to be laboratories for development and testing of interventions. And so folks swoop in, they swoop out. And there may be a few people that get the benefit, but it could be more beneficial if you have the right folks at the table who are deciding, like I said, about the intervention and even how to evaluate it. What does success look like? Success for a researcher for a particular program may look very different for someone who who's meant to benefit from that intervention. So that's primarily how it permeates, at least it impacts my work, is really helping to drive the research agenda so that it helps to bring in the right people at the table to conduct research to minimize stigma, minimize the stereotyping, et cetera.
Excellent. Thank you. Thank you so much for that. I'll go to you, Mr. Fischer, for this, because I know that this is something that is very forefront for you in what you're trying to do at NAMI.
Yeah, Brian, it's interesting. And I love Dr. Baytop's response, especially as it relates to research, because within the research arena, whether behavioral health care or others, one of the things we find is that people of color tend not to be included in those research studies. So when Dr. Baytop says, well, the wrong questions are being asked, it's because we're not at the table creating the questions. And so we have to, and I say that to say this, we have to look at how the pendulum swings both ways. Are we not being invited to participate? Or are we being invited and we're not engaging in participating? And that rears its head. I think that's a version of stigma itself. Sometimes we turn down opportunities to participate in research because we don't want other people to know. It's that simple. It's not just that we don't want to take the time. Sometimes we don't want our families and friends to know that I'm participating in this dental study or mental health study or whatever it may be. And we have to be careful. And I'm big on taking responsibility. We can't keep blaming them if we're not going to participate. We have to participate. We have to be, what's the old saying? If you're not at the table, you're probably on the menu. We have to be at the table and participate. Now, within, there was a study that was conducted a few years ago that demonstrated that when physicians engage with African Americans versus our Caucasian counterparts, physicians tended to be 23% more verbally aggressive and 33% less patient-centered than engaging with Caucasians. And what does that mean? It means we're being talked at instead of talked with. We're not being given the same options, not only the same treatment options. In my world in behavioral health care, we talk about self-determination, patient-centered planning. I want to have a say in my outcome. In the behavioral health care world, I don't just want to get medication and therapy. I want you to treat me holistically, because we recognize that there's value in those, what we call social supports. Maybe I want to go back to school. Maybe I want to have a family. Maybe I want to participate in my community and my church. Don't just put me in a box and label me and shove me in a corner. Let me have some say in what my future is going to look like. So again, stigma is so powerful, and it covers such a breadth of area in our life. And we have to be our own best advocates. We have to advocate, but most importantly, we have to participate. We have to stop finding reasons or excuses to not be a part of the solution that we seek. And I don't mean to speak in these cliche terms, but we are the change we seek. But we have to participate. We have to stop waiting for somebody else to do it for us and give it to us. One of the most powerful lessons I learned, I've been executive director for NAMI Michigan for 10 years, and I didn't recognize this. Actually, one of my funders brought it to my attention some years ago, and she said, "Do you know why I support you so much?" And I said, I thought about NAMI and what a great resource NAMI is. She said, "For the first time," and I happen to be the first male, I think I'm the only African-American male state executive director at NAMI. And I'm the first African-American executive director here in Michigan. And she said, "People need to see leadership in the behavioral healthcare community. We can't always be the patient. We can't always be the recipient. They need to see you out there." And it has really changed the landscape here in Michigan for the people or the community that seeks and participates in behavioral healthcare events. The demographic has shifted. And I say this with humility, it's not about my leadership necessarily as an individual. It's the fact that they see me in a leadership role and that I'm there. And I think that helps destigmatize mental illness, because people in our community say, it must be okay. He's there. He's leading the effort. And so I'm really proud of that. And I want to see more of us do that. Get involved, get engaged. That's how we eliminate this stigma.
Thank you for that, Mr. Fischer. I think you're right. I see Dr. Perry, I see you over there writing furiously. I want to get you in on this.
Oh, I had so many responses. So, I'm in 100% agreement. And what kept coming to mind was the Tuskegee experiments, the lack of trust, right? And so, you definitely hit the nail on the head. But as a clinical researcher, I want to add that, let me set the stage. Speech language pathologists, okay, there are only about 300,000 of us that are certified by the American Speech Language Hearing Association. You don't necessarily have to be certified to be an SLP, but you should, right? We always say it's best practice. And you can still practice with a license in your state, but you need a state license. Now I'm going to say, out of those 300,000, less than 5% are Black. Okay, so this is where the problem comes in. When you said, I don't think it's a dichotomy of either or, and you were leaning into that, right? It's not just, are we not being invited, or are we not showing up, we're not engaging. It's also that the table that was set is not a table that we eat at. So Japanese people eat on the floor at a table, okay? Every culture has a table that they eat at. If you invite me to a table that I don't know what, you give me chopsticks and I'm used to a fork, of course I'm going to withdraw. Of course, I don't know the game. And so the system is a game, and it perpetuates itself. I just told this to my class earlier. An object at rest stays at rest unless an object of equal or greater force moves it. We have to get in the system. That's the only way to change the system, is to get in it and move things around. Okay, it's not going to shift itself. So you're right in that we do need to engage more as consumers, but also on the producer side. We are not producing at the rate that we should be, and it's not our fault. The system doesn't want us in these spots. If there was a need, and there is a need, but if there was a desire for more Black speech language pathologists, more Latina speech language pathologists, or Latina or Latinx, whatever you want to say, more of any minority or any minority group for that matter, whether cultural, ethnic, or whatever, we would create spaces for that. But systems perpetuate themselves. And so they're looking for people that look like them. They're inviting people that talk like them. They're speaking the language of the people, who speak the same language. I just said, many of us speak African-American English and we don't know it. We don't even, because we get offended. Someone says you sound Black. That's offensive to some people. But it's the truth, okay? And not everyone who's Black speaks African-American English. We're at Howard University in Washington, D.C. My dissertation was on Latina students who learning how to write paragraphs in English, who were born speaking English, raised speaking English. They also spoke Spanish, but they had Spanish influence in their writing, and they had African American English in their writing. These were children from El Salvador, but they spoke African American English because they're raised in Black communities. And so, just that stigma, it's not about color, it's about class. And you spoke that, Dr. again, Ms. Baytop, I'm not sure, right? When we talk about classism and social economic status, and sometimes it's not necessarily about your race or your cultural linguistic group, it's also about your class, right? What class are you in? So African Americans in middle class might not be able to understand the issues that African Americans in poverty face. Okay, so we also have to speak to the level of class that people are at and be able to invite them in a manner that allows them to feel comfortable with sharing and with being vulnerable. Because when you're in healthcare, you're allowing yourself to be vulnerable. So that's just my 2 cents. I don't hear any audio. Do you all hear audio?
Oh, sorry about that, guys.
There he is.
I'll go to you, Dr. Grant Mills, on this because I saw you
Yes,
nodding.
just to follow up, I want to echo everything that's been said, just regarding the impact, the tremendous impact that stigma has on all the work we do, from an interdisciplinary position, working collaboratively across the disciplines to, again, prepare our future practitioners to work together to advance individuals, families, and communities. And again, at Howard University, Dr. Perry and I work closely as part of an interprofessional committee that engages students. Our charge is to move us out of our silos, because we recognize that in order for us to address those critical issues facing our nation, and using the word vulnerable citizens or vulnerable residents is just not enough, because our nation's most vulnerable are actually placed at risk. How are they there? Why? What are the conditions? And what are we willing to do collaboratively to, I would say, indict those systems that are bent on, as Kevin just said, not being inclusive. And so we look at how that also impacts the lifespan of communities. So many interconnections are there. But when we look at the academic institution, Howard University being a center for resources, a resource net for communities throughout the metropolitan area, we take very seriously our position to positively impact health outcomes by developing the curriculum that will ensure that by learning together, our future practitioners, whether they are dentists, physicians, nurses, allied health practitioners, we are closely connected with the School of Social Work. Now we've expanded our interprofessional reach to the School of Law, School of Divinity, Departments of Education, and most recently, the College of Fine Arts, as we engaged students, about 214 students across disciplines at the university, in an interdisciplinary approach to medical humanities, art, and healing, applying healing to improve quality of life and health outcomes. There is tremendous work to be done, and we consider ourselves fortunate to be at a university which is committed to producing leaders and those who are going to be change agents and are equipped to go wherever there is a need. And that's, I think, one of the biggest problems facing our nation is to not only increase access to care, but also improve access to careers. And those are some of the projects that we have been engaged. And we see that building academic community partners where stakeholders at all levels are together, working together. And so those stakeholders include the academic institutions, the practitioners, the health professions organizations, our clergy, policymakers, all of us working together to see that one of us can't do it alone, but we all have a part to play. But we can't see the goal if we stay in our silos.
Mm. Wow. Wow. Thank you for that. Thank you for that, Dr. Grant Mills. Listen, we're going to take a break, everybody. Let all this kind of sink in with our audience. But when we come back, we're going to take some audience questions and see where this conversation leads us. So everyone stick right there and we'll be back with more our health forum in just a second. Have you ever asked the question, if I was to be anything, what would I be? Regardless of money, regardless of status, beyond popularity and fame. Living your passion, feeling your life has purpose. Soulivity is a space to nurture that which lives in all of us. A place where work can become play, and doing what we love creates the dreams of a lifetime. And we're back with more of our health forum on stigma, national health crisis here, which is part of our Bridging the Gap Health Equity for All Health Forum series. Let's get to some questions, y'all. I know some of these came in as we were speaking, and so I'm going to try to get to as many as we can during this time, and then we'll go do some final thoughts after this. This was anonymous, but it comes in as, let's see here. Is this the right one? I guess this is going to you, Dr. Baytop, and I guess everyone else can kind of come in too. There are many ways to ask a question, but the only catch-22 is when the medical person or researcher is when the medical, I don't know what that means, see a person like myself who is also medically labeled for the right reason, but we are also not at the table. This goes to Kevin Fischer. He said, I am also a white Australian person joining in from the far north tropical coast of Queensland, Australia. I've been an advocate myself for the past 18 years since I found out my true identity on my own. I will also be putting myself out there too, but it does not get me anywhere where we're all either. And he's put a smiling face. Any comments on this? I mean, I'm trying to understand what his question is, or is it just a comment here?
You know, really quickly, Brian, and I did read the comment. I am terrible for our audience. I am terrible at following the chat and the Q&A and trying to stay focused. But I did, during the break, take a peek. And first of all, I have to say to my friend in Australia, one of my favorite places to visit. I was there a few years ago, and I look forward to coming back. We have to become comfortable with being self-advocates. I mentioned it in my comments earlier. We can't wait for somebody else to do it for us. But there has to be, there has to be a comfortableness that comes along with that. I tell many families and people who've experienced a loss of a child like I have, this isn't for everybody. It's not easy every day for me to get up and talk about my son. I relive losing my son every day. It is a part of my work. And some days are better than others for me. But I say this, I didn't choose this. God chose me for this. And so I have a certain sense of comfortableness in doing what I do. Not everybody's ready to step out on that ledge. And then, do you have the social supports in your network to reinforce you, to lift you up on those days that you know, those tough days? And so I applaud you for stepping out and becoming an advocate for yourself. And I encourage you to continue to do that. I'm a huge proponent of self-care. And so I would say, make sure you have the supports in your network or your community to lift you up when you're not having your best day.
Wow. Thank you. Thank you for that. Let's go to this next one. This is also an anonymous one, but I think it's a really, really good one. What strategies can healthcare providers implement to overcome the language barriers while also addressing and reducing stigma? And who wants to take this one? I guess that this can go to you, Dr. Perry. We'll take you first.
Okay, great. I think a big thing that healthcare providers can do, and most healthcare providers are trained on some aspect of cultural competence. So that is integrated in every profession's curriculum from a pre-service training level. However, that doesn't mean that everyone's good at it. And we are moving away from cultural competence to cultural humility, because that puts you at a position equal to, rather than I know. You don't know anything, right? We're all learning, coming. And so, one of the things that I recommend to other speech language pathologists is to pursue a cultural broker. So you can't change the fact that, you're born the race that you're born, you're from the culture that you're from. And many of us get very locked in because the culture is a mindset. It's a paradigm. It's a way to view the world and how the world works. And we all have a culture that we are aligned with. White people have a culture, white Americans, because when I say this in Europe, that what is white in Europe? It's about the country you're from. So this whole color concept is an American construct and it's not real, first of all. So when we get outside of the American mindset, which is the new world, so it's a new way of viewing things, and we go back to the old way about just cultures and different people from different geographic regions and from places, I think that right there breaks barriers and allows us to see that we're all equal. There's no one above another. All languages are equal. All dialects are equal because they're all rule governed. If it's a dialect, that means it's running off of a system. So if I were to speak African-American English and I violate the rules, then I'm going to sound funny to someone else who speaks it because it's rule governed. So that means all languages are equal. No language has better rules than the other. You don't go to Spanish speakers and say, why do you use the subjunctive tense? No, okay, it's the way that the language works. So when you start to learn other languages, when you start to eat food at different restaurants, you begin to be humble because you understand that your way isn't the only way to skin a cat. And so just for, as a professional, I would say pursue a cultural broker so that because you don't know what you don't know. I didn't know that when I was dealing with certain Asian families, especially Eastern Asian families, that I should speak to the male. I didn't know that because when I deal with many African Americans, there's a matriarch involved, and I generally will speak to the matriarch of the family about the problem, right? So it depends on the setting as well, who's the caregiver, right? So when you start to understand that each culture has a different value system, the first thing you should do is just check your values at the door. But many of us aren't aware of our values because we only operate in one culture. So we need to give ourselves opportunities to interact with people, to feel funny, to stumble trying to say something in Mandarin because we sound funny. Put yourself in their position and ask someone from that culture if it's okay. And if you don't have a cultural broker from that culture, if you don't have someone that you can go to and ask, if I'm approaching appropriately, ask the patient, ask the family, just ask first. We assume and we follow protocol, and sometimes we lose sight that the protocol is a guide. It's not a textbook, and it's not a script. It's not one way. Treatment, we're supposed to accommodate the patient's needs, and it's supposed to be individualized. That's our oath of beneficence, is that we're providing individualized services. And so how could you disregard someone's culture if it's not individualized? So if you don't want to be at a position where you're liable for negligence, right? Then you want to, as a professional, ask, is this appropriate? Is this okay? We deal with patients with swallowing disorders in hospital settings. Oftentimes when I'm dealing with patients from Amharic or Ethiopian backgrounds, I don't have to modify their diets like I might have to for a mainstream person, because I know that many of their diet is pureed. So if I'm dealing with a patient with a swallowing problem and I'm saying I need to downgrade the diet to puree, I might not need to do that for someone from an Eastern African culture because they already have food that's pureed. So, what is the point of me telling you you're already doing it? So again, just having an awareness of, what am I asking this family to do? What am I asking this patient to do? What is the outcome that I desire? And is it already being met? Is it just that it doesn't fit my script? Because the script, again, it's not prescriptive, it's a guide. So having cultural brokers engaging and coming out of the walls and interacting with people with other cultures and asking questions before you make a movement or make an assumption, I think will put you in a place where, at least if you fall short, there's a saying, love covers all sin. And it is true. I can always show that I was doing the best thing for a patient if I act out of love, if I humble myself, and if I ask questions. It will cover me if I make a mistake. But if I don't act out of love and I act out of, I want to build extra services because this is an opportunity to build more, I want to get them out of my way because I have 10 people in front of me. I've got to meet these demands, or I don't understand what they're saying, so let me just quickly get through this. That's when I become negligent as a provider, and that's grounds then to have malpractice issues because I didn't put the patient first. So if you can't do anything, just act in love.
I think we can all agree. Let the church say amen,
Amen
to that. Wow. Thank you for that, Dr. Perry. I really appreciate what you just said. Why don't we go to this is a question from CM Tharper, and he's asking, or she's asking. Well, just want to make sure that I read the whole question here, because this came in while you were talking. When scientists conduct research, they establish a control experiment to other data. Typically, it is a neutral case. Similarly, when people interact in intercultural environments, the baseline behavior in America is highly influenced by the predominant population of white people. Having said, how would Valencia recommend that we modify the recruitment initiative so more people of different ethnicities get prioritized? Why don't we move this around a little bit? Because I know Dr. Perry, you just broke some stuff down, so I want to make sure we get our other panelists in on this. Dr. Baytop, let's go to you for this one.
I have to say, I was anxious to hear Dr. Perry's response to the question. But one thing I want to slightly answer, to try to answer the question, but to build on what Dr. Perry said, that I was definitely in the amen corner, is about having a cultural broker, and that cultural humility is so underestimated, right? Like you said, coming from a place of love, but coming from a place of love means you're coming from a place of humility. And that is as simple as a researcher, again, going back to even a survey where you ask questions and you even if you want to translate into Spanish, you may have people who know Spanish, who were trained in Spanish, but if they are not from a particular Spanish ethnicity, it could turn out to be something totally different than what you intended, right? So we are in this project in particular, we have been pushing NIH to spend the money to actually find people from the community and different dialects, different ethnic backgrounds to be consultants. Pay them the same way you would pay a PhD, pay them to help us, translate a survey so that it makes sense. And where it doesn't make sense, to be very clear to us about how to make it make sense, or if it's not even relevant. Because oftentimes, again, we might be asking questions that are just not relevant. So I just really, really wanted to stress, I really appreciate you talking from that place of love and humility, because it really does make a difference. And that's why it's so important for, as Kevin Fischer, I almost call him Dr. Fischer as well, as you said, that it is important for us to be at the table. It really, really is. No matter what your degree, what your background, we definitely have to be at the table to drive the research agendas, drive the development of the intervention so that they really are relevant for those who truly, truly need it, not relevant based on the schooling that I got, not relevant based on my implicit biases. Like you said, you come through the door, and even me as an African American from a certain class, certain education, I may still have those biases that I need to check myself and be aware and come with humility to say, look, I don't have the same lived experience, so help me understand what makes sense, what would really work for you. I think that's just it sounds easy, but I think we have a long way to go to get folks to understand just the importance of that perspective. And I'm sorry, and in terms of the question about and I'm not sure about the question. I think this is kind of something that we've been talking about even at Westat about, experiments. Yes, you may have a control that's supposed to neutralize things, but there's still room for bias. There's still room for bias in terms of how you interpret the data, right? I see Dr. Perry is agreeing with me. So even though we have randomized controlled trials to try to equalize things out, there's still biases, inherent biases, just by virtue of the questions that we ask. The way we look at the data, you can give the data to two different people and you can manipulate the data in a certain way, not a bad way, but in a way that doesn't necessarily answer the most important questions and about the effectiveness of intervention. So I just want to, I'll just end with that.
All right. I'm about to, you guys are about to make me pick up a white handkerchief in a minute here. Start waving it around. Dr. Perry, the floor is yours because I know you want to get in on this.
You know it. I'm thinking of studies we've done in speech language pathology where we'll have, we'll follow the protocol and we'll have the little babies come in if it's a child language study. And we'll say, okay, mom, we want to play with your child, right? And what do the Black babies do? Okay, so the toddler or even the school age Black children, we'll ask them questions and they'll give us a one-word answer. We'll ask, mainstream children, and they'll give us an elaborate sentence, and they'll point out all the things. And so we'll ask the Black child. Well, we have to ask the parents, why aren't they talking? We realize, well, African American children were taught to speak when spoken to, and they're taught to give the right answer, and so they'd rather say less and be accurate than to say too much and say something wrong. So we had to change our way and make it more play-based and more, because the African-American children tend to be more community-oriented. And so learning is a social construct with them. And whereas in mainstream cultures, and even in the classroom in the school setting, we're taught to be more individualized, right? It's not necessarily group learning. So that's construct validity. The way that the test is constructed is invalid for the user. There's a thing in technology where it's called UX designers, and they get paid very well. These are people who just go in and test platforms as a user. Researchers don't do that. That's called pilot testing, but they lose sight of that and they do pilot testing with the wrong population, or they'll base protocols off of data from other groups instead of off of the target group. Again, there's more than one way to skin a cat. So just because it works for this group, it doesn't mean it'll work for another group. We know that in healthcare, especially with blood pressure, there are certain medications that they naturally will give to one population that they will not give to African Americans because of other risk factors. And so that's debatable as to why. But the point is, I love what you said because it resonates with me, Ms. Baytop, about make it make sense. That's a common colloquial term that the youth use. Make it make sense. And how do you make it make sense? If there's something that you're doing on one side of the equation, you need to do it on the other. So if you're designing a research protocol for a specific end user, an avatar, then you need to make sure that the avatars respond well to the protocol in piloting. Make it make sense. And so by involving the community, like you said, from the outset, from the design, from the construction, getting their input across the development, instead of at the end creating a cake and bringing it to them and then saying, oh, I didn't know you didn't eat pistachios. Why didn't you just ask at the beginning? We would have told you, would you give a Jewish person a pig? No, you would not. right? And so we're saying, come have a pork with me. If you just asked, you would have known that they look at swine as the bottom, the pit, the scum. So it's a matter of making it make sense by incorporating them across the continuum from development to dissemination, rather than waiting until the product is formed, the treatment is developed, the protocol is set, the system is in place, and then saying, let's see if we can get some more people of color to join. No, it'll never work. It'll never work. They're in two different paradigms.
Right, right, right. And again, I can see everybody's just kind of just amen and nodding on this. I mean, the cultural aspect of this seems so important, and that we've got to bring that to bear. Got another question coming in, and this is for you, Dr. Grant Mills. I just want to make sure that I'm pulling this up correctly here. He says, when will those change the attitude in the way that they see those like myself is a major problem? Hey, just kind of like moved on me. It's all the questions are coming in now. Let's see, where is it? Where was I? Oh, did they take it off? They didn't want to. I guess they didn't want to ask that question. So we're going to move to another one because they took it off of here. Let's see. This one is one I've been trying to save, but I think it's about time that we get to it. And that is, this comes from Jada Coleman. And she says, how can my participation with this event impact the population/issue that we are addressing today? And so I'm going to go, I see you smiling, Mr. Fischer, on this one. So I'll go to you first, and then we'll go down the list of our panelists here.
I'm going to be really brief because I want our colleagues to have time to weigh in on this. Your participation here, and I said this earlier, we have to be the change we seek. So by virtue of your participation here tonight, I encourage you to take what you've learned and your own lived experience and make sure you share that in your community. That's what's really important here. We can't just keep preaching to the choir. We have to get out there and be the change that we seek. So that, to me, is the value of your participation here tonight.
Thank you for that. Thank you for that. Thank you for that. Dr. Grant Mills, I'll go to you.
Yes, follow up on what Dr. Fischer just said, showing up and participating. I learned that as a teenager in a community where, as I said earlier, we had, there were no physicians, no dentists, and there was a lot of unmet need. But there was the president of the PTA who said, I'm going to mobilize efforts. And I tell you, everybody involved in this community, we raised monies. Federal government said, because we did not have a health center. And so we raised money. I was a teenager, and that's when I learned that you have to be part of what you want to see. And you have to claim it. And, you have to be in it. And more than 50 years later, that my community where I grew up is now in its third health center that has only expanded. Federal government said, community raise X amount of dollars, and then federal government will match it. And so we started, as I call, with small beginnings, little efforts, but with a view to change the life experiences for a large number of people. And I sometimes when I'm in the community and I drive past this large health complex now, and as I said, we did not have a dentist or a physician, but with that community effort and in other communities supported us. And that's how it starts. And I know that the work I do today is informed by what those leaders in the community who just encouraged us, who opened the pathway and showed us with whatever they had, they shared. And I wanted to just add to that, what we are doing in academia is focusing also on integrating the practice of mindfulness to improve patient-centered outcomes. The clinician, the humility and the practice of mindfulness. As we see our future generations of practitioners, we are confident that we're going to turn a page on the disparities, largely meeting yourselves where you are, but also engaging the community and meeting the family, everybody you meet where they are, and with humility, and like Dr. Perry said, coming from a place of love and that practice of mindfulness at patient-centered outcomes. You know, we will have a shared identity as providers to make that difference. So I thank the participant for that question, because it starts small, but it has such a powerful impact on what the outcomes will be.
Thank you for that. Dr. Baytop, what about you? What are you thinking around this question?
I'm not sure I have much more to add. I feel like my colleagues said a lot of what I would say, especially in terms of being, getting involved, participating in whatever you can, and whether it's research activities, if there's a study, showing up, or even before that, I mean, if you're a healthcare provider, there's a lot of like satisfaction surveys that go out, or like opportunities to show up and and provide feedback. And I don't know if we do enough to make sure that we're there at that table providing our feedback, taking the initiative to be involved and to help direct services, et cetera. So I really do appreciate the question as well.
Thank you for that. Dr. Perry?
I'm over here in class. Class is in session. Okay. Be the change you want to see. Come on, Gandhi. And showing up and participating, all that makes me think of is the squeaky wheel gets the oil. And so many times we just reduce ourselves. I have a few things to add. One is, for healthcare professionals, we need to practice at the top of the license. When you practice at the top of the license instead of at the bottom of the license, it frees up space and time. You delegate things to your assistants. So almost every professional has an assistant. Speech language pathologists have speech language assistants. Occupational therapists have CODAs, certified occupational therapy assistants. And when we do the things that only we can do, we can free up space and delegate tasks to our assistants to help us get things done. Nurses have nursing assistants. Okay, so that's one. Stay in your lane. Sometimes we are looking for gratification. We're looking for acknowledgement. We're looking for anything, attention, and we're doing too much. When you delegate, that frees up mental space so that you can do what only you can do, okay? That guy from Facebook wears the same shirt every day. He wears a gray shirt every day so that he doesn't have decision fatigue, because your tank, once it's empty, okay? Patients deplete us. In healthcare, you get depleted by the nature of the work, service. And so when you're practicing at the top of the license, you're protecting your mental energy and your mental space so that you can solve problems. So 2, be honest. We lie to ourselves, okay? We have to stop lying to ourselves. Research teaches us how to be honest. Research is about seeking and exposing truth. And so if you're a true investigator, then you're going to always align with what's true, because you're using tools to establish truth. So whether you're a qualitative investigator and you're triangulating your data and you're doing it in different ways to find themes that speak to a certain truth, or whether you're doing it in mixed methods or in a quantitative modality, you're not going to just say, well, because I go out and get 100 samples that I have enough power that this means that this works. No, that's true for the people who align with that sample that you've collected the data from. Did you collect? One of the things that they do in speech language pathology, and this is in several published assessments, this is how, because someone asked about how people get misdiagnosed in the schools. They get misdiagnosed because the language is standard American English and they're using it for people who don't speak that dialect. And I just told told you that dialects and languages are equivalent. Just because I speak a dialect and you speak a language, it doesn't mean that my dialect is less rule governed. It's still rule governed. If you ask a DC person right now, why are you lunching? They're gonna say, I ain't lunching, you lunching. Okay, but if you say that and they're not from DC, they're gonna think that a luncheon is an event. They're not gonna think it's a verb. They're going to think it's a place to be. So that right there, that's a dialect feature. We have different words, we have different tenses, like I said. So, you want to be honest with yourself and ask yourself, am I doing what I should have done? Did I set things up in the correct way? And same as a consumer, be honest with yourself. We know when we're not getting right services, and yet we still come back. You have a choice. I don't care if you have Medicaid. Medicaid pays money. This is why at Howard, we teach our children, forgive me, Lord, they are grown-ups. We teach them to bill. We teach them medical billing and coding and speech language pathology so that they understand the value of the services that they provide. There's a dollar amount to the service that you provide, and you need to understand what Medicaid is paying, what United Healthcare is paying, what Care First is paying, so that you can decide if you want to work for the system or if you want to step out and be in private practice, you have the capacity to do that. So we realize that the system isn't always, it's going to perpetuate itself. It isn't always going to consider our demographic. So instead of telling all the students, hey, go work in public schools, which would be great because we want to change the schools, we're also telling students, go start a business. Why not you? Why not you? Because you haven't seen someone that looks like, look at me. So back to you, Mr. Fischer. I see so many students blessed by just seeing me. Just seeing me. You're Dr. Perry, you from DC, you, single mom of 3, you. So just seeing someone in the position allows you to conceive it. Once you can conceive it, then it can become your reality. But your feet, Cindy Trim says, is your feet would never take you where your mind has never been. Many of us cannot conceive that we can have what we deserve. Right. And so mindfulness, Dr. Grant Mills, I was laughing when you mentioned it because you're absolutely right. Consumers and healthcare providers can be more open to the truth when we become more mindful, because we realize that our thoughts are not our feelings. They are separate. And sometimes a thought can trigger a feeling. It doesn't always mean that it's true. So if you change your mind, you will change your life. How do you change your mind? You have to change your paradigm. Get outside of your culture. The world does not exist in a vacuum, and the world does not run off of even mainstream American culture, okay? Because China is, I don't know, but I'm about to get me some yen. So don't think that your way is the only way, because it's not. There are multiple ways to skin a cat, and forgive me, all you vegans.
Woo! Okay. All right. Listen, thanks to all of our attendees for the questions. I know we've got tons more. We'll try to get some of these questions out to our panelists afterwards, and we'll try to get those answered either on our chats or we'll try to email you, because we have your email addresses for today's session. But I wanted to end today. We've got a bit of time. If we can do these in a couple of minutes, just kind of going through our panelists, what final thoughts are you feeling? I mean, around this forum, around some of the questions that were asked today. It can be open, but just what are your final thoughts? And Kevin Fischer, I'll go to you first.
So, first of all, I am grateful to be a part of this forum. My esteemed panelists, thank you so much. I've learned so much. To the participants and the questions, thank you for being here. Your presence and participation makes this educational for me, for all of us as well. To my friends at Howard University, Dr. Perry, Dr. Grant Mills, I'm coming there because I'm trying to get my honorary doctorate degree. So y'all invite me, I'm coming. To everyone, and I know this sounds a little cliche, and I mean it from my heart. And Dr. Perry, thank you for saying this, because I remember saying this when I took this job at, when I took this position at NAMI. I said, I will make mistakes, but I don't make big mistakes, because one, I've been trained to consult others, get others in the boat with me, and not make big decisions in a vacuum. The other is I make them out of love, because I do this because of my love of people. And that helps me minimize the mistakes or the size of the mistakes that I make. for all of us, get involved. If you get nothing else out of this forum tonight, get involved. That's the change. Dr. Perry said it. I think all of us have said this. Just our mere presence changes the game. There's a saying I see on social media that says, you don't have to sit at the head of the table, because by your presence, the table will shift because you're there. Get involved. Brian, thank you for hosting this forum. I look so forward to doing so much more. My last thing is, I wear my Everybody versus Stigma brand, and I'm not on here to sell t-shirts or anything. Everybody versus Stigma is a movement. It's not a brand. And Stigma, I utilize this concept in the space of behavioral health care. But as we've all learned tonight, stigma comes in many, many forms and affects us across our lifespan. It's a conversation starter. I get stopped every place I go, restaurants, hotels, airports, everybody. Hey, what's that stigma thing about? That's how we normalize the conversation. That's how we eliminate the stigma. So I encourage everybody, get involved. Thank you.
Thank you, Reverend Fischer. Appreciate you. Appreciate you. Dr.
You
Donna
know you're
Grant
trying to get
Mills.
stuff started with this reverend thing. Okay.
Well,
Dr. Donna Grant Mills. Yeah, go for it.
Feeling encouraged, inspired, and highly optimistic for what we are going to realize, and thankful for what we realize, because from this panel, I know that we're headed in the right direction, because each of us are connected to a whole group of others who are there with us fighting. And the participants are here tonight because they're on that path as well. And together, we are casting a net, and and with the perseverance, the patience, because that's what it takes. It takes a lot of patience, and most of all, faith. And I always say, to my self, a lot of times when faced with challenges, but facing those challenges, but also being thankful for what I'm about to realize if I would just remain faithful. So I sometimes pray, say, thank you, God, for what you're about to do if I would just remain faithful. And I looking forward, that is our stronghold. Again, I'm fortunate to be part of the Association of Minority Health Profession Schools. We are about 12 schools across the nation, minority serving schools, producing, the largest number of practitioners who go out and serve their communities. And again, we emphasize humility and having a capacity and a willingness to serve any community, any place in the US and the global community. And despite the advancements that we've made in the 20th century in technology, still too many people in this nation and around the world are not smiling. They're not smiling. And we can do more. We can do more by working together, stepping out of our silos and working as a team, training, learning together, so that we are a shared identity and making positive health outcomes for the nation and the global community. And thank you for the invitation to serve on this amazing panel.
Thank you for your service. Thank you for your service. Dr. Baytop.
So first, I do want to say thank you as well for having me on this panel. Definitely, I feel like we need a reunion in DC. Come on, Kevin, Brian, and we definitely need to get together and continue this conversation. Because I do feel very much uplifted. Because I have to admit, at times for me, I am at a company that is predominantly white, and being one of three Black vice presidents in of 2,000 employees, is sometimes I overlook that and forget that. And forget how important it is for us to be in leadership positions. As you said, Dr. Perry, I mean, it really does make a difference for those who are coming into the company and for the communities that we're working with, that we're conducting, that we're partnering with in research. I've made an effort to ensure that the team that I have of 70 staff is as diverse as possible, for the same reasons that we've discussed tonight, to ensure that the voice of different communities are represented and can help push the envelope, can help educate other researchers, can help educate the government, and reduce the stigma by being at the table and having such a diverse group. But I feel encouraged, though, that there are folks at different places around the country who are really fighting the same fight. And I absolutely agree with what Kevin said again about how important it is to get involved. I mean, it really, in any way, shape, or form, it is imperative. That's the only way that we can really combat inequities, is to be at the table, to be part of the leadership, to make sure our voices are heard, and partnering with the community. If there are any researchers on this call, if you're not from the community, it's definitely an invitation to learn more, but coming with humility. I want to just stress that what Dr. Perry says, because it really does make a difference in ensuring that we're, again, conducting research that makes a difference, that is sustainable, that really is having an impact. So I just want to applaud my colleagues for the work that they're doing, and really am honored to be on this panel. And for those who have joined, I'm hoping that you too feel encouraged to continue on in this effort. So thank you.
Thank you. Thank you for that, Dr. Baytop. Thank you. Thank you for your service too, because this is what this is about. Dr. Perry, Reverend Deacon Dr. Perry.
I was going to say, in the words of Reverend Dr. Fischer, and be the change you want to see. We could just echo that, right? Because repetition sinks in. And so many of us, culture programs you, and culture programs the way that you think. Mindfulness helps to deprogram you so that you can recognize automatic thoughts. When I see a cell phone, I have a trigger, okay? So that's an automatic thought. And so you want to find what your automatic thoughts are. That's how you begin to change your mind. It's a neurological, it's physiological. Your nerve impulses have habitual pathways that they go through when they have certain triggers. That's how the brain is efficient. The mind is the faculty, right, of the brain. So when you can change your thinking, it changes the physiological structure of your brain. Okay, so that's first. So be the change you want to see, change your mind. If you can change your mind, you can make one decision that can change your life, because you're thinking differently now. So you're going to attract different results, because when you think, as you think, so you do, so you become, right? That's how you be the change you want to see. As you think in your heart, so are you, so you become. And so you first have to identify your values. There are certain, and here's another phrase like this common, stand on business. What do you stand on? Do you stand on saying? Are you wavering? If somebody says, well, this patient needs a biopsy, and you're saying the patient doesn't need a biopsy, but because someone of power said the patient needs a biopsy, are you willing to risk your license to put in an order that you don't agree with? You have to believe, you have to stand on what you believe. If a doctor tells you that you need to take a medication and you really don't believe that medication is good for you, maybe you've tried it. Maybe you've had certain side effects that you believe are a result of the medication. Are you able to advocate for yourself and say, this isn't working for me? How do you do that? Data. You take data, you document. So whether it's today I feel sick, every time I take this medicine, I feel nauseous. Put it on your iPhone notes. So when you go back to that doctor, it's very difficult for a healthcare provider to argue with data. Okay, we don't want to look stupid and we don't want to have malpractice. So if you have data saying one thing and we're telling you to do something contrary to what you, the patient, are saying, remember that's not acting in beneficence of the patient. That's not putting the patient first, and that's not individualized patient care, resulting in the best outcome for the patient. No one wants to disagree with you when you do that. So again, you have to be the change, right? You have to love yourself. Many of us can't love others and can't love our patients because we truly don't love ourselves. We beat ourselves up. And like Dr. Grant Mills said, we're not patient. Love is patient. I don't need to quote the verse, okay? But that's an attribute of love. So if you're not patient, if you're not long suffering, you're not acting in love. You don't know that you're not acting in love because you're not being mindful to say, what I did yesterday, was that acting in love? We're not taking the time to take stock of what we're doing. We're moving, but we're not stopping and reflecting, and we're not planning. That's a part of life as well. It's not always just movement. Energy does go where energy flows, but we have to direct the energy somewhere. When you open your mind, you change the channels of where you're directing your energy. Your results will change. Okay, so what do you need to do? You need to dream big, but you need to take small steps. Dreams overwhelm us. It's a lot to do. So if you take small steps, you can make it bite-sized and palatable so that you can move in the direction of where your vision is aligned. But if you don't become mindful, if you don't take time to take stock of your activities and of your thinking and of your worldview, if you don't get outside of your cultural group, you'll never be able to know what it is to do next because you're always in the movement. Okay, you're always in the noise. So, we go into the noise and we work in the noise, but we have to step out of the noise. And again, that's embodying, practicing at the top of the license. That's embodying showing up. That's embodying being honest, being accountable. And another thing Reverend Dr. Fischer said is working in teams. Being clear, being transparent. How did you spend the money? I spent the money on these books, right? So being honest and keeping account. You have to keep an account of what you're doing, logging it. That again, that data. There's always patterns in the data, but if you never go back and look at the data, you'll never see the patterns. So yeah, dream big and take
Mm,
small.
mm, mm. We got some final housekeeping to do with a couple of things, but I'm just going to say this to the four of you, specifically as it comes to health outcomes across all disciplines, across everything. What I feel the conversation tonight is redefining what it means around the Hippocratic Oath. Do no harm, right? Redefining what that means. And if we're not actually, adding in the cultural aspects and the other social determinants of health, and we're not looking at this holistically, we're harming people. And that's the bottom line. That's the bottom line.
Exactly.
We're harming people.
That is,
We're,
yes.
we're harming people. And so thank you all for being part of this. We're not ending here, everyone. We're not ending here. We're going to be doing these forums at least twice a month, sometimes 3 times a month. We're trying to expand this. And so there's a way that you can do that. But before I get to that, we are not finished. As I said before, we've got another forum that's coming up. It's actually an educational webinar. If you do not know about APOL1, kidney disease, you need to know about it, especially if you're part of the African American community, because this gene is affecting 13% of our population. And if right now there is no FDA approved cure, and that it's a crucial aspect of healthcare that is not being talked about, but we're going to talk about it with NephCure next Tuesday at April 30th at 7:00. We'll be broadcasting their live educational webinar, which is celebrating the inaugural National APOL1 Kidney Disease Awareness Day. So we're going to be doing that here on all of our channels, and we'll also be broadcast on KMET 1490 AM radio out in Southern California for all of our listeners out in the out west. And if you want to be an attendee for that, visit eventbrite.com and search for Soulivity. It's there. Sign up and be part of the change that you want to see. Also, listen, we want to celebrate all of our fantastic partners, from Mount Sinai to the Institute for Health Equity Research at the Econ School, to NAMI Michigan, to Howard University, to Research, to NEPCare and KMET. Thank you, thank you, thank you, thank you, thank you. This is a growing list. If you want to become a sponsor or partner or supporter, please email us at bridgingthegap@soulivity.com. We'll take the dollars, but we'll also take the change. So please email us, become part of the change that you want to see. And if you want, to know more about just what we're doing broadly with Bridging the Gap, just visit our website at soulivity.com/bridging-the-gap. And you can learn more about everything that we're doing. Listen, y'all, I know we're running a little bit over time. My cup runneth over with this. I could not have imagined a better inaugural health equity forum. This is what it's all about. I created this in remembrance of my father, who passed away a couple of years ago. Stuff that I didn't know about his condition that I know now. And so I'm trying to pay this forward and trying to bring as many people on board talking about certain specific things, and then we're going to broaden it out from there. So thank you, my panelists today. Again, my cup runneth over with all of you. And thank you to all of you out there who watched today. You took action to find out more information. And so this video is going to be available on all our channels. You can share this out to your followers. Please let people know that this is an issue that needs to be solved. And so we can't keep harming people when we know that we're doing it. So we have to move forward. So on behalf of everyone here at Soulivity, our partners, our amazing panelists, this is Brian Wesley Johnson saying thank you for joining us for this evening. And as you move forward with your lives, keep having conversations like this with some passion, some purpose, so that we can all create a high quality life, our best life today for everyone. So thank you again, and bye for now.